of policies such as the subsidized school fruit scheme, food-based dietary guidelines, and the legislation relating to energy, legislation for labeling energy. But on the other hand, we have very poor implementation of policies to promote active travel, to influence food prices, or to signpost food products. I'm just giving a very quick illustration of effective policies that are known to be either unevenly or insufficiently implemented across the European region. And even as we come to measurement, we're measuring a lot the outcomes and the risks of NCDs, but as illustrated by this slide from the Marmot Review of Social Determinants of Health in the United Kingdom, the type of indicators that they would like us also to measure extend way beyond the outcomes and indicators, policies, and processes of NCD, but they go into wider areas such as early childhood development and young people, the proportion of young people not in employment, education, or training. We have much more to do in order to collect the adequate information that can be used for policy making. As we come into the discussions on the Global Action Plan, I urge you to consider, therefore, what is the role of UFA, what is the role of every public health practitioner, and not only in helping to measure the burden and the inequity or equity of distribution of NCDs, but also a full range of actions to look at the equity impact of all policies, to enact the evidence-based laws and regulations, to influence the governance of health in order to reduce the social determinants of non-communicable disease, to affect personal behaviors, promote healthier environments, enter into partnership with civil society and appropriate work with the private sector, to increase the prevention content and investment within health systems, to promote universal coverage and address the local determinants of health in cooperation with local communities, and to build up the infrastructure for health promotion across Europe. To some extent, this slide could be the subject of a whole plenary discussion in itself, but it is intended to generate in you a germ of some ideas that we would like to hear, within which we would, the general parameters within which it would be nice to hear how we can bridge the now very technical agenda of implementing the targets of the global monitoring framework on NCD into our well-accepted now ideology and evidence on the importance of social determinants of health and of non-communicable diseases. So with a hope that you will go look at the monitoring framework and form your own ideas and tell us what to do, I thank you for your attention.
Before I introduce our next speaker, I want to introduce my co-moderator who's just arrived, Dr. Simon Busuttil. He's a member of the European Parliament, and what's significant about his membership, in addition to his duties at Parliament, he has won the European Parliament's prize for the most health-oriented member of the European Parliament, so we're fortunate to have him with us. He will take over the moderating of the Q&A piece. I'm going to introduce our next panelist, Nesime Salioska. She's the Executive Director of the Association of Roma from Macedonia, which, from its establishment in 2006, pledges for better integration of the Roma community.
Good afternoon to everyone. At the beginning, I would like to thank to the organizers for inviting me to this conference and for giving me this opportunity to be a plenary speaker together with the respectable doctors, professors, and also policymakers, as I'm nothing of that but just a Roma activist who is trying to address the health obstacles among the Roma population and advocate for the solutions which will eventually secure equity and access to services as a basic human right of every person. Namely, I must mention that this is a privilege for me, but also for my colleagues from the Open Society Foundation and civil organizations, to see that our efforts on raising awareness about Roma health issues several years in a row by organizing different events in the framework of the annual conferences finally were recognized and acknowledged at this year's annual conference by my presence at this plenary session and as an evidence on how ground activities can be transformed towards contribution to the improvement of public health. As an introduction to my presentation, I would like to mention that when I was invited to this plenary session, I asked myself why I have to talk to this session and why to not talk in another session with a different topic. Then I looked closely to the topic of this session and I found out that the name of this session is Small, Few and Different. And that's why I wondered what exactly means to be small, few and different. Then I Googled a little bit and I found out several explanations by which you can see on the screen an explanation which I took from a dictionary which is providing some inside looks of the words. Afterwards, I reviewed the situation of the Roma community and tried to relate these definitions and see if there is any connection. Surprisingly for me, and probably for many of you who are here, is that the Roma community fits in every aspect of these definitions. The Roma community is small due to the fact that it is the most marginalized community, not adequately represented in public and political life, and often not acknowledged and supported by the society. For illustration, I will tell you that almost all Roma communities are living in ghettos located in the periphery of the cities and towns. Then it is few because of the invisibility in almost all countries across Europe in which they are residents. Just as an example, I will mention that the Roma community is the largest ethnic community in Europe of almost 10 million inhabitants, according to field research. But authorities fail to follow their presence and migration, and this is why if you search for the official data, you will find significantly lower numbers, just like in the case in my community from where I come from, where according to the official census, there inhabited 4,445 Roma, but according to our research, there are 8,000 Roma living in the same community. And finally, why they are different? Well, I must tell you that discrimination, prejudices, and stereotypes on the ground of ethnic origin are part of the daily life of the Roma, as it was responded by 60% of the Roma in a survey at a glance undertaken by the European Agency for Fundamental Rights. Having in mind that all of these definitions about what means to be small, few, and different, and the observations of the situation of the Roma, I finally found myself to be relevant for this session and to give a speech on the situation of the Roma community. In terms of exploring the disadvantages, I went more deeply with my questions to the extent of how small, few, and different can be the Roma compared to the non-Roma, and then I found a study published by the UNDP in 2006, where there is outlined different level of poverty among the Roma and the majority. If we look at the chart closely and focus on the blue color, which represents the percentage of people living below the poverty line, we will notice that the difference is outstanding in the case of Roma, and it is the same situation in all 9 countries which were subjected to the research. So I will ask you, can we imagine how is it to live with $2 per day? I assume that almost nobody of the present here can imagine, but believe me, Roma are surviving every day with the amount of money which illustrates the disadvantages on the daily basis. And then looking at the barriers in health among the Roma population, the evidence showed there is higher perinatal and infant mortality, lower vaccination rates, higher level of chronic diseases and disability. Women particularly are disadvantaged, then inequalities in access to high-quality healthcare services, life expectancy gap, inability to afford prescribed drugs, and lack of health information and promotion. I will not argue about the causes of these disadvantages, as I assume that many of you have attended the events organized on Roma health issues by my colleagues throughout this conference as a Roma health program named Healthy Roma, Healthy Europe, but I will try to review The public policies which are intended to tackle these barriers is a state responsibility which has to secure equity and access to its citizens for fulfilling needs. My review has a good and a bad news. Firstly, it was good that many governments in Europe, EU member states and non-EU member states recognized the need for adopting national policies intended to address the problems of deep social and economic exclusion of Roma. It mainly happened throughout the preparation of national strategies for Roma as a multidimensional national policy to undertake affirmative activities towards the real needs of Roma, and luckily, one of the priorities was the reducing of gap in the health status between Roma and the rest of the population with focus on the access to healthcare. Parallel to this process, or as additional for some countries, it was launched the Decade for Roma Inclusion as an international initiative to bring governments, intergovernmental and non-governmental organizations in accelerating progress towards the improvement of the welfare of Roma, and once again, health was one of the priorities in the produced country action plans predicting systematic approach towards the faced obstacles by Roma in access to health services. Having these two very positive policies towards the improvement of the health status of Roma, it was expected that beneficiaries will be satisfied very much and that services will be reached to those for whom they are meant. Aiming to evaluate this satisfaction, coalitions of Roma NGOs and activists from all countries participating in the Decade initiate an outstanding monitoring mechanism named Decade Watch, as it represents an assessment of government actions on implementing the commitments and giving Roma a voice in the process of inclusion. The initiative was supported by the Open Society Foundation and the World Bank. Unfortunately, on this slide, we can see some bad news. When we see the percentage of Roma who were very positive towards the question, how do you assess the impact of programs addressing access to primary health care, we can notice that the satisfaction is not near to 50%, or among the 11 countries which were monitored, only Spain gave the highest percentage of 33%, and in other countries, they are so low up to 0% in 4 countries. On the following question, to what degree do health programs bring about desired change, the percentage is similar, and in particular, in the Czech Republic, Bulgaria, and Montenegro, the degree was assessed with 0%. As we continue to work on the field, individual measures showed to be ineffective and the government ignorant towards the real needs of the beneficiaries. If we look at the case of the Macedonian policy as a country which is in pre-accession process, we can see that there are mechanisms to prevent discrimination in access to healthcare, and their work resulted with no registered cases on Roma patients who faced discrimination treatments by health professionals up to date. Yet our organization, Roma SOS, which is a grassroots organization located in the southwestern part of Macedonia, by working on the field, has documented many cases of Roma who were not informed, not adequately provided with basic health services, or not even adequately treated when requesting health protection. These 4 cases, which are presented on the screen, are just a rough illustration of that how serious inequalities are facing Roma in Europe, and why we feel like we are on the front line having a battle to access health services, and not only in a way to prevent diseases, but rather to save lives. Secondly, it was good that the European Commission sent a proposal to all member states and those who are in pre-accession process to change the situation of Roma, and it has been welcomed as a political signal that states are willing to make a tangible difference to the lives of the Roma people. EU framework for national Roma integration strategies was adopted on 5th April 2011 as a commitment by EU member states to promote the inclusion of their Roma communities. However, the bad news is that the European Commission assessment in May this year highlighted that the majority of member states have so far failed to allocate sufficient financial resources for Roma inclusion. Only 12 countries have clearly identified allocated funding, whether from national or EU sources, and presented specific measures for Roma inclusion policy measures in their strategy papers. And we all know that without financial and human resources, policies are just a paper of words. Having in consideration all of the mentioned data, actions, measures, and evidence regarding the implementation process of public policies and the effects on Roma life, our analysis of the obstacles are guiding us towards the following. Public policies are old and do not address the real needs of Roma, have piecemeal approach and lack indicators to measure the implementation on national level. At the EU level, we notice that there are good intentions, but the lack of political will by part of the countries does not allow matching of policies and statements, and thus governments do not fully use EU money due to the lack of knowing how, as well as due to the lack of administrative capacity to absorb EU funds. Guided by the fact that this is a concluding plenary session and that evidence should be transformed into public policies and followed through implementation, I will give my conclusions in terms of what can be done to ensure inclusiveness of Roma as a take-home message to overcome disadvantages of those who are small, few, and different. The first conclusion is nothing about us without us. Beneficiaries are the ones who are able to identify and prioritize their own problems and needs. The approach has been practiced through the community monitoring initiative launched in several countries, among which is Macedonia also, and where on the issue of immunization coverage among the Roma children was opened a participative process for providing recommendations by the community to the policymakers when creating the program for active protection of mothers and children. The second conclusion was clarity on who has the responsibility for monitoring. I will mention that in many governments, national contact points for Roma issues are having the role of the implementation and monitoring of the policies. This creates a cycle of no implementation, no revision, and no accountability towards the implementation of policies. An independent body will undertake this monitoring process and will provide additional